Brooke Abbott.
And I'm Amber Tresca, and we're the co-founders of IBDMoms. We're moms and inflammatory bowel disease patients, and we've created a safe space for other moms with Crohn's disease or ulcerative colitis to share their journeys with one another.
The IBDMoms podcast will focus on topics such as body dysmorphia, sex and intimacy, how to parent through a flare-up, and transitioning kids from pediatric care to adult care.
Thanks for being with us. We are here to help moms on the challenges they face on their journey through motherhood and chronic illness.
Hey, Amber.
Hey, Brooke.
So today we'll be talking about fissures and fistulas. I'm super excited about this topic, actually, because even though I've never had an experience with fistulas, I have had a fissure or two in my life. What about you?
Yeah, no, I had a kid that had a fissure, and that was a whole thing. But thankfully, I really haven't had any perianal complications. And so not having any personal experience, of course, we did what we always do. We found an expert, and we found one in David A. Schwartz, who is a professor of medicine in the Division of Gastroenterology, Hepatology, and Nutrition at Vanderbilt University in Nashville. He founded and is currently the director of the amazing Inflammatory Bowel Disease Center at Vanderbilt University Medical Center, which he told us all about.
I'm super excited about this episode. I think a lot of people are going to get some good info, so stay tuned.
Coming up next, Dr. David A. Schwartz. Dr. Schwartz, thank you so much for joining us on the IBDMoms podcast. We're so excited to speak with you.
Thanks, Amber. Thanks, Brooke. I'm really glad to be here with you today.
Dr. Schwartz, could you just take a moment and tell us a little bit about your background and your interest in inflammatory bowel disease?
Sure. I did my training at the Mayo Clinic about a long time ago now, 21 years ago. And I really just completely fell in love with taking care of IBD patients. It was probably the one thing in medicine where we have medicines that really actually work. And because this disease process affects younger people, we can have a tremendous impact on a patient's life. And I've now been doing this long enough that not only have I taken care of patients, but I've seen them have kids, and I've also now taken care of their kids. So it's sort of a nice merger of kind of primary care and specialty care, and really lets you get to know patients and really have a significant impact on their life.
So our topic today is fistulizing disease, so I want to jump right into that because you're the expert. And we often talk about IBD and how it affects the digestive system, but I think some patients might not realize that it can also affect the perianal area, which is that area around the anus or the booty hole. So would you tell us, Dr. Schwartz, what are the kinds of perianal complications that go along with IBD?
Yeah, there are several. So the most common one is probably perianal fistulas. And kind of the best way to describe this is sort of a tunnel that connects the rectum to the outside or to another organ that results from just the severe inflammatory process causing a defect in the wall that then extends over time. Some patients will also get perianal fissures. I like to describe this as sort of a paper cut or tear in the anal canal. It can be very painful, and then also anal ulceration. So there's a number of different perianal complications that go along with perianal Crohn's disease. Probably about 40% of patients will have one of those or multiple ones of those during the course of their lifetime.
So how would someone know if they're actually developing a fissure or a fistula? And in addition to that, how could they start that conversation with their doctor? Because that seems kind of odd to say, it feels like something's tearing down there.
Usually, the most common thing patients will recognize will be perianal pain. So pain is the sort of the first presentation with an anal fissure. Maybe they'll have a little bit of bleeding associated with it. With fistulas, you also will get drainage of either purulent material, pus, or stool. And sometimes patients will not know if that's just a little bit of incontinence or actually drainage through the tract. And if they examine their bottom, they might see a little divot or opening that has a little bit of pus coming from it. And sometimes doctors who don't take care of a lot of patients with Crohn's disease will not know exactly what this is. So it's really important that you go to someone that is very familiar with Crohn's and the different manifestations, because we treat it very differently if it were because you can get an anal fissure without Crohn's disease, you can get a fistula without Crohn's disease, and we treat that very differently in a patient that does not have Crohn's disease.
I'm actually so glad that you mentioned checking, because I feel like a lot of patients don't check in that area at all. And it's so important because you really should know, what's going on down there.
Yeah, and I think it's important when you first meet a patient that's having any of these manifestations to kind of talk them through what to expect. Because the other thing I didn't mention is a lot of times patients with perianal disease will get skin tags, and that can cause a lot of distress and sometimes pain. And also, a lot of doctors, again, aren't familiar with that, and we'll call that a hemorrhoid, which it's not. And so it's really important that the patient knows their own bottom and can recognize changes and report that back to their doctor.
I've heard from so many patients who are misdiagnosed with a hemorrhoid first off because maybe they're unable to look or nobody actually does look, like even their healthcare provider isn't looking. Do you have any sort of tricks for somebody? Like, do you recommend like a mirror? do you get that granular with your patients?
No, actually we do. So a mirror is a great option if someone doesn't have a significant other that can help them. But a lot of times I just ask them to get their partner to take a look, and if they're comfortable with that, and get a baseline, and then they can kind of follow things over time. That's particularly important when we'll get into this, I think, probably a bit later, when a patient has surgical treatment for this and has a ceton placed, and that's something we want them to track over time. So it's really important to know your own bottom, or your partner know your bottom, and kind of monitor things.
I love that. My husband always knows when I come to him and I'm like, okay, I'm really sorry, but I have to ask you to do something gross.
Hey, that's marriage, right? That's marriage.
That is marriage. My partner knows my bottom. So you mentioned treatments briefly. You mentioned aceton. What are some of the treatments that are now available for fistula? And, I think a lot of people also want to know, is there stuff that's coming up in the future, new treatments?
So the first thing I'll say is it's really important to go somewhere where they have a multidisciplinary approach to this, because 20 years ago when I was first kind of learning about this stuff and training, the concept of working closely, a gastroenterologist and a surgeon was really very foreign, and we just didn't do it, and we weren't getting really the optimal outcomes. What we do is very complementary to what the surgeon does. We help each other out and really maximize treatment options. So for the surgical approach, what we're really asking a surgeon to do is sort of clean up all the infection that's there. If there's an abscess, for instance, they drain it, or they put in a tube to help it drain. And for the fistulas, we ask them to put in what's called a ceton. And a ceton is a string or tube that goes through the fistula tract, if you can picture it, in a circle. So it goes through the fistula tract and then comes back around through the anal canal. So it freely rotates in a circle. And the idea is to keep the internal opening open and the external opening open, so all that purulent material can come out and the medicines can work most effectively. For medical therapy, we've gotten a lot better in our options when the introduction of anti-TNF antibodies like infliximab or Remicade came out. That really helped improve the care of patients with fistulas. The problem is that even under the best care, only about 30 to 40% of patients will have long-term, greater than a year healing with those medicines. We definitely need adjuvant options or better options that can help really get the majority of patients better, not just the minority. And I'm very hopeful because in Europe, they have this treatment which uses allogenic adipose stem cells, so fat stem cells that other people have donated and they've cultured and expanded, and they inject them into the fistula tracts. And in patients that have failed medicines like Remicade, they were able to get over half of them better by using this new treatment option. We're in the middle of we just completed the study in the U.S. that hopefully will lead to its approval in the U.S., but because of how long that whole process takes, we're probably looking at a year and a half before that comes to market here in the U.S.
I mean, dare I say that's exciting to hear just all the things that are coming down the pipeline for people to have so many options. That's amazing.
Yeah, a lot of my patients who have been struggling with this for a long time, I will tell them, there's a light at the end of the tunnel. Just hang in there. When this becomes available, we'll roll it out to everybody, and hopefully we'll really improve the patient's quality of life when we can.
So I've never had a fistula. I've had a fissure while living with a toddler, which was Baby, that was what a time. Emotionally, physically, trying to just take care of the house, take care of yourself. But living with a fistula, I know, can be even more difficult and even more emotionally draining and physically draining. What are some of your suggestions for women who are coping with some of the ways that a fistula could complicate their quality of life, such as intimacy, being physical and active in their own lives?
Yeah, it can be very difficult. We know that women and men actually who have significant perianal disease, it really negatively impacts their sexual quality of life. Some studies even suggest that up to 97%, almost everybody essentially with this, have a significant negative impact on their sexual health. So it really requires just open discussion. If the person's in a long-term relationship, involving the partner to help explain what's going on, and a lot of planning as well. There are things, as I mentioned, that we can do to help with the pain, help with the drainage, and really slow down or eliminate the drainage completely to help improve the quality of life. And really being at a center that has psychosocial care and can involve the patient, not only the patient, but the partner in that kind of counseling really helps go a long way to improving that.
So we know that IBD patients who are educated about their disease do better. So I'm wondering, where do you send your patients so that they're not going off and finding something that is very scary or not very helpful? They're living with a fissure, they're living with a fistula. What do you recommend so that they can learn more either on their own or maybe with some direction?
There is not a lot of information on fistulas or fissures online, unfortunately. The ones that are perhaps the best are, there's a nice infographic on the CCF webpage about perianal fistulas that I find very helpful if someone wants to get one sort of snapshot as to what to expect and how prevalent it is and the treatment options. WebMD and UpToDate have good patient-related resources. But there really needs to be more. And one of the things I'm very excited, obviously, about this new treatment option becoming available in the U.S. But with that, I think there'll be a lot more attention to this problem and more resources for patients when that gets closer to being available.
Can we talk a little bit about the Vanderbilt IBD Center? We know that this, it takes a multidisciplinary patient-centered approach, which we heard that you referred to as a medical home, which I love that, because when it comes to living with a chronic condition, you need some sort of base and a place where you can go and get everything taken care of at one time, because being a patient is hard enough. Being a mom is hard enough. Being both it's a lot.
It's ridiculous.
Ridiculous is a good word. Dr. Schwartz, will you talk to us a little bit more about the Vanderbilt IBD Center and what they have available for patients?
Sure. I'm proud to say that we were the first medical home for IBD in the country, and it kind of came from the realization that we were doing a pretty good job of treating the small intestine, treating the colon, but we weren't really treating the whole patient. And both Crohn's and ulcerative colitis affect so much more than just your GI tract. And unless you really address those other things that the disease impacts, you're really not going to get optimal outcomes. And so I've put together a team that involves a psychologist, several social workers that do counseling, pharmacists, nurses, doctors, and NP and PAs who are all trained in IBD. And the idea is when a new patient comes, we tell them they're going to be there for 3 or 4 hours, but we're going to make it a very comprehensive evaluation. The patient sees one of our mental health providers first, then they see one of our dietitians. We have a brief team meeting to kind of discuss points that came up in their visits, and then we go in and meet the patient and talk about their medical side of things. If they have any ongoing issues like anxiety and depression, which we know about half of our patients do, they can continue to see one of our mental health providers in our clinic or now virtually. It's virtual care has become really very important in what we offer. So they don't have that stigma of having to go to a separate mental health facility. And similarly with the dietitian, they can plug into our dietitian resources to help them with some of their dietary issues. Malnutrition is a big issue, particularly when people have active disease. And a lot of time people have gotten just terrible advice on the internet or from friends who are well-meaning, but really have actually made their symptoms worse. And so it's a lot of undoing of bad advice and trying to set them on the right path. And we're also increasingly becoming interested in dietary therapies as adjuvants to our standard therapies. And so we're trying to incorporate that into some of our treatment approaches. And I think that kind of that whole team approach is really, really important to getting the best outcomes when you're taking care of patients.
Wow. Okay, so I guess I'm moving.
I know, right? It sounds wonderful. And we're so grateful that you have this available to your patients. Is there any social media that you can share with us where patients can find you, can find the Vanderbilt IBD Center so that we can direct them to you?
Sure. So my Twitter handle is IBDDoc09. And we have a website for our clinic. It's VandyIBD, which is one word, .com.
Dr. Schwartz, I want to know a little bit more about you. Do you have any favorite trips that you've taken that you could tell us about? Where's your favorite place to sort of unplug and relax?
I absolutely fell in love with Spain. I just find the lifestyle fantastic. The food is amazing. The people are amazing. Lots of history, and it's beautiful. My wife and I often joke that we might retire there. It's just such an amazing place. So that's where I would go.
Why is it a joke, though? Couldn't you actually retire there, you think?
I don't know. It seems like I'm a very conservative person in general. It seems like a big, kind of a risky thing, I guess, leaving the country, but maybe. You never know.
Well, we thank you so much for talking with us today, for everything that you do for patients and for making yourself available online to discuss these issues and to bringing more treatments for fissure and fistula. So thank you so much for joining us.
My pleasure. I really enjoyed this.
Great. Thank you.
Hi, this is Jax, and you're listening to my mom, Brooke Abbott, and my aunt, Amber Tresca, on the IBDMoms podcast. Just because I don't listen to her doesn't mean you shouldn't.
Hey, Brooke.
Hey, Amber.
Hey, I wonder if you would listen to my mommy meltdown for a minute.
Girl, I got you.
I need something to happen to stop these TikTok challenges that are invading the kids and making them do crazy things. I feel like every week I'm having to talk to my kids about some other dumb thing that's going around the TikTok.
Yeah.
Are you having the same experience?
Oh, gosh. Yeah. It's annoying.
It's annoying. And recently there was this one chip challenge situation where there is this, I don't want to call attention to like brand names and whatnot, but it's this idea where there's a chip that is dusted with like hot pepper, and to me it kind of sounds like a Dorito chip or something like that. And then you're supposed to just like eat the chip, and it is so hot, spicy, that I've heard people eat them on podcasts and they can't talk for like a minute. Like they have to deal. Like it reminded me, my kids were laughing at me because I told them this. It reminded me of maybe like being in labor and you get to a certain point with the contractions where you can't.
There's no talking. There's no thinking.
No.
I literally just went there. You just got that. I was like, oh.
All right, I have not eaten one of these chips. I'm not doing any TikTok challenges. I'm talking to my kids at least once a week about some challenge that's going around. Thankfully, the school is on it, and then I'm pretty clued in. I listen to like a lot of news shows and stuff. So, but of course, I know these things are spreading before I'm ever hearing about them because I'm an old mom. But like I'm just tired of trying to have to be out ahead of it.
Yeah.
And I would really just like it to stop. I would like this challenge culture. That's what I'm going to call it. I haven't heard anyone else say that. I'm coining it right now. I would like this challenge culture to stop because I'm tired of spending so much time thinking about how I have to talk to my kids about it, ask them if they know anything about it, ask them if they know anybody who is doing it, ask them if they think it's a good idea, because I just don't go after them and go, don't do this thing. Like, you know, I'm that kind of mom where I make them have a conversation with me about it.
Yeah, same.
And I'm tired of it. Like, I'm exhausted with it.
Also because we have 10,000 other things to do. There's only so much that we can do. Like, we should all be working together to help raise children and raise the future and make sure that the future is safe, not, you know, shoving Tide Pods down their throat and eating NyQuil chicken. Like, and the stuff just sounds dumb.
It's dumb.
We've all done dumb things. Granted, you and I never had them recorded.
I don't know, man. I just don't do stuff like that. I never did. I was boring. I'm still boring.
But this is different than like ding dong ditching someone or prank calling someone. You know what I mean? Like,
yeah, you know, which neither of those things can be done anymore, by the way.
Oh, no.
All right. I subscribed to a newsletter, and in the newsletter, in my email, came in a warning about don't steam your vagina with magic mushrooms. I actually posted about it because it caught me so off guard.
Oh my God.
And there was somebody who DM'd me and they said, do you remember when people used to talk about soaking a tampon in vodka or whatever and using it because that would get you drunk? And I'm like, yeah, that was a thing. Look, in my day, yes, that was a thing. I've never known anyone who did that.
Are you serious?
But I definitely know people who talked about it or knew of it. But I've never known anyone who did it.
Wait. I've never heard of this, and this is really tripping me out. I've never heard of this.
Well, here's the thing. You don't steam your vagina or your vulva. By the way, the vulva is on the outside, the vagina is on the inside. People get that confused all the time, and they say your vagina or I can see your vagina. If you can see my vagina, then you are a lot more intimate than
There's a lot going on.
There's a lot going on there. Okay. So, all right, you may be able to see someone's vulva, but you really got to be between their legs if you want to see their vagina, because the vagina is on the inside. Okay. So when I had my first baby, I had a really funny nurse who came in and was giving my discharge instructions, and I had had a vaginal birth. And she said, all right, this has a lot of stuff on it. I'm just going to tell you one thing. Don't put anything in your vagina. Not one thing for 4 weeks. And I was laughing. And she was like, I find that there's too much misunderstanding. And if you tell people don't put in a tampon, they'll think that they can have penetrative sex. Or like the reverse, you tell them not to have sex, but they think that they can use a tampon or something. So she's like, so now I'm just very clear, don't put anything in your vagina. And like, look, it's a rule. Like, don't put stuff in your vagina that is not made to go in your vagina. Okay? So I don't understand why we have to keep going over this, that it was a thing in my day that was going around, soaking a tampon and whatever. Now I've heard like CBD, like all these things. And I hope I'm not like giving people ideas, but like don't put stuff on a tampon and then put it in your vagina. Don't eat really hot stuff on a dare. Like, that's just dumb. Don't put NyQuil on your cheek. And I'm kind of like, I need the challenges to stop.
Yeah.
I also have grave concerns, and this is like my being boring mom again. I have grave concerns about people who think it's okay to record pranks or record challenges, and some of these things are not real. They're using camera tricks and things like that, or delayed recording or whatever they're doing. And then it is me that is having to tell the elders in my family or the children in my family that what they saw on video is not real, and convince them, because, you know, I'm just a mother, I don't know anything. So I have to convince them that it's not real and make them believe me when they literally don't believe me about anything, even things that I am an expert in. So it's really just wild, and I need that to stop. And I am also going to say, if people know of a way that moms are keeping themselves informed about these things, I would really like to know what it is, because I need to be a step ahead of it, because I'm tired, I'm exhausted by it.
Yeah, no, I feel you on that. That would be great.
If they're spying on the teen grapevine, like I need this.
Where's the mom form?
Well, we do have the IBDMoms Facebook group,
There's
so maybe we can use that to back channel and sort of warn each other about these odd things that are coming along, and so we can just head them off and have conversations with our kids about it and help each other out a little bit.
You can find it at facebook.com/groups/IBDmoms.
I love how you knew that. I couldn't have said, if you asked me, I wouldn't have been able to tell it to you. Thank you, Brooke.
Thank you, Amber, on that. I'm going to go make myself some fall coffee. Hey, y'all, we made it to episode 3. I'm so glad y'all are still with us. Links to a written transcript, everyone's social media handles, and more information on the topics we discussed is in the show notes and on the episode 3 page on IBDmoms.org.
You can follow us across all social media as IBD Moms.
IBD Moms podcast is written, produced, and directed by the IBD Moms, Amber Tresca, and me, Brooke Abbott.
IBD Moms would like to thank Takeda Pharmaceuticals for their support of this program. Mix and sound design is by Mac Cooney. Theme music is from Cooney Studio. And then a clap. 3, 2, 1, clap. 3, 2, 1. Are you waiting for me to clap?
I was waiting. I don't know. I was trying to be in sync. I'm not the Temptations, okay? I don't know how to work in sync.